All right, my name is Oron Frankel. I am a graduating resident at Highland Hospital, Alameda County, Department of Emergency Medicine, and this is an introduction to tropical medicine for traveling doctors. I basically did this presentation because I wasn't able to travel this year to learn about all the cool tropical medicine that I really wanted to because I had a child, and so I basically had to do my learning from home and hopefully made it interesting and useful for you as a primer. What we're going to cover is basic introduction. My goal is that you're going to have cognitive triggers for a lot of these diseases. We've heard about them a lot, we learn about them a lot, they're talked about a lot, but when you're out in the field, what are the things that are going to make you think about something clinically so you actually remember and don't just have to kind of dive into your book, because they're not really written for emergency doctors. And we want to be able to just think about these as emergency doctors. I'm going to cover the top tropical illnesses, what I call the top 10, based on incidence factors that I've been able to see and suss out, and that's going to be what you're going to be traveling and you might not be familiar with from home. I'm going to focus on basic epidemiology, diagnostics, and intervention strategies. Different areas will have different things to worry about, and that's up to you to do the research ahead of time. But I'm going to give you limited details because treatments are going to be relative to what kind of practice you're in, what your situation is, what kind of resources you have. My bottom line, the first thing to remember from this talk is to get this book. The Oxford Handbook of Tropical Medicine, right here by Edelston et al. Will be your lifesaver. It was super interesting, it's very well written, clinically oriented, and can really help you guide through the problems you're going to face. What I should say is that we're not going to cover HIV and TB, clearly super important, but basically topics upon themselves and also relative to what you're and how you're working. And the other thing is to remember that this is about how to treat folks who live in the areas that you're going to be traveling towards, not you, and not people who are returning travelers, because that's kind of a totally different world. So this is basically geared towards what you'll see in clinics and hospitals that you're going to be traveling to, largely in the tropical world. Some of them may be naive or travelers themselves, but you'll see them there. It's not about fever in the returning traveler, which is kind of a totally different talk. All right, let's get to it. Tropical medicine, top 10. Top 3, malaria. And then there's going to be dengue. We're going to talk about typhoid fever. Then we're going to talk about what I call tropical diarrhea, schistosomiasis, other helmets of distinction, leptospirosis, the syphilis of the tropics, and then a group of miscellaneous items that I think are interesting and worth covering also. So, number 1, 2, and 3 are going to be malaria. 300 million cases every year with 3 million deaths annually. You can see on this map the red zones are where there's malaria basically all the time, and then yellow is more seasonal and spotty malaria, and green is kind of in the free zone pretty much for malaria. There are a couple key points of understanding the life cycle. Don't worry, we're not going to go into sporozoites and merozoites. The thing to notice is up in the upper left, you see the infection from the mosquito. These infective things go into the blood. The thing to notice here, though, is that they're going through the liver. They all go through the liver. That will be important in a minute. And then it basically spreads from there into the blood and kind of starts replicating in the blood cells themselves. Clinically, malaria is fever plus. So anyone with a fever, you're going to be thinking about malaria. So here are some take-home points for malaria. Besides that, anyone with a fever, you think of malaria. If there's malaria and someone has a fever, it's probably malaria. But that is a caveat. First thing, fever, malaria. Cognitive trigger. All right. The second point to take home is that in different regions, different parasites. So I've broken it up as there's falciparum, Plasmodium falciparum, and then there's everything else. And that will be important because there are the quote benign malarias and the quote malignant malarias. Malignant is falciparum. And you have to know the distribution of where you're going to be because different places have different malarias. So remember, there's falciparum, then there's everything else. And the last thing is that there's acute versus chronic malaria. This is going to relate to what the transmission is like in the place. So some places have stable year-round transmission. People all are constantly exposed to malaria because it's always there in everyone and just spreading around through mosquitoes. And so in these places, you're going to mostly see cases of malaria show up to you for help in people who are young children, pregnant women, or immunosuppressed or travelers. Everyone else is just constantly exposed, and they're not really going to have bad symptoms. In unstable areas, you'll have seasonal bursts of malaria, and anyone with a fever needs to be considered at risk. All right. So in stable malaria, basically you're looking at young children, pregnant women, and anyone else who's immunosuppressed or who is naive, like a traveler who has a fever. You have to think malaria. In unstable places, anyone with a fever should be considered to have malaria. Got it? Good. All right. So clinically, acute malaria is this classic paroxysm. First cold rigors, then high fever, and then they get coated in sweat. And it's basically rinse and repeat, right? Rigors, fever, sweat. Rigors, fever, sweat. If there's other things like swollen lymph nodes, if people have a rash or they have a sore throat, you need to consider alternate diagnoses because these do not go with malaria, and they're going to key you into some of the other things on your differential because every time you see someone sick with a fever, you're going to think about malaria, but then you have to look for these other things that might be cueing you into everything else. But remember, fever, malaria is number one on your differential, no matter what. So this is where it becomes important to think about the severe malarias because if you're in a falciparum area and someone is sick, you need to consider cerebral malaria. This is basically malaria plus encephalopathy and seizures. And you're going to do your normal things, right? If someone comes in febrile and altered, you're going to do your regular tap, you're going to make sure their glucose is normal, and then you're going to treat them probably for bacterial meningitis and for malaria, and you're going to pray for them. Right? Because at that point, cerebral malaria has a 20% mortality rate. The other thing is that people with severe malaria and falciparum malaria can be anywhere on the spectrum to multi-organ system failure. So they can look like our sickest septic shock patient from this parasite load and this intense anemia and hemolysis process that's happening everywhere. To diagnose malaria is a little bit tricky. So you need to consider a wide differential, right? Just because they have malaria, just because they have a fever and either in a malaria region doesn't necessarily mean they have malaria, right? Because a lot of the people in these stable malaria areas all have malaria already. So even if they just have a fever, it's probably something else that they're coming in with their fever. So you need to get blood smears, but they can be misleading, right? They can be falsely negative. Sometimes a single negative can be a false negative. And in these endemic areas, people will have false positives and they're actually there with something else. So when you're in doubt, the CDC recommends treating with both antimalarial treatments and probably antibiotics, especially if you're worried about something like cerebral malaria. I'm not going to get that much into treatment principles because this is going to be super complicated. I'll show you in a second why. But the bottom line to take home is that uncomplicated malaria can be treated as an outpatient. You do not need to admit these people to any hospital or clinic. That is with a caveat that it's okay to wait for smears, but if someone's smear comes back and they had just a fever and not too much else going on, but they had a huge parasite burden, like tons of parasites on their blood smear, you need to be really worried about them because those are the folks who can decompensate fast. It's like the lactate of the malaria world. So if you see high parasite burden, those folks need to be potentially admitted for intravenous treatments. The rest of the folks, if they don't have any immunity, like it's a traveler or it's someone severely immunosuppressed and they have falciparum malaria, that is another high-risk patient. But otherwise, if they have a benign malaria or in the endemic region and they look well and they may have falciparum, but they're not in those ones of extremes of age or extremes of immune system function, then they can be treated as outpatients. And the agent of how you treat is going to depend on what you've got. So this is the CDC flow sheet on how to treat malaria. I've zoomed in on the treatment and you can already see, like, there's no way you're going to remember this. So you need to have this ahead of time. You need to know what's available to you. You need to know what's in your area, what's your sensitivity area, and then you're going to treat accordingly based on what your clinic has and what you're going to do. I'm not going to get into this anymore. All right. But I do want you to remember some things about malaria. First, fever malaria is always on the top of your differential, right? It is the great mimic. It can do pretty much like pretend to be anything if someone has a fever. And then you need to take falciparum really seriously. People can get super, super sick and need to end up in the ICU with intravenous treatments. Okay, that's enough on malaria. Let's move on. So next is going to be the other mosquito-borne illness we're going to talk about, which is dengue fever, rapidly rising with up to 100 million cases per year now. And it's thought that urban areas are the most risk, where there's water concentrated and mosquitoes can breed, and it has kind of the perfect storm for dengue fever. And it's also in this kind of tropical belt, which is going to make it pretty hard on your differential, especially initially, because how do people present initially with dengue? It's pretty soon after their mosquito bite, but they have what the classic break bone fever. Basically, people are like in super severe pain with their fever, but this is usually benign, right? They look terrible, they're miserable, they have myalgias everywhere, they have like crushing pain behind their eyeballs, they have this scary, crazy rash, the classical hemorrhagic vasculitis with, quote, white islands in the sea of red, right? People like petechiae, these little like purpura petechiae everywhere, and they look terrible, but then they're going to get better. The other thing that makes the differential difficult, because you're going to say fever, what's number first on your differential before dengue? It's malaria. But the other thing is people often get GI distress, and that makes it really hard to tell from AGE or typhoid, which we'll talk about in a minute. So it's a little complicated to know, but the good news is the treatment is basically supportive care. The issue with dengue fever is the unfortunate small group of people who end up with severe dengue, hemorrhagic dengue. And those are folks, right, that you get this petechial rash because you get a mild thrombocytopenia, you get a little bit of capillary leak, a little bit of blood goes into lots of places all over your body, but most folks are able to cope with it. Some people, though, unfortunately, based on some serotypes of the dengue and also their own body, end up with severe leaky capillary syndrome, and they basically have a severe warm shock. It looks, for all intents and purposes, like any other really bad septic shock. You're going to treat them the same way. Supportive, pressors, fluids, and you're going to hope for the best, right? And they're going to just be bleeding, and they're going to get fluid in their lungs, and they're going to get ascites, right? It's like leaky vessels everywhere, and it's going to be bad, and they can get altered, and you're going to be worried about them pretty bad. So, a lot of the exam and lab findings are not that helpful. Who do you worry about then with dengue? Sometimes it's going to be obvious if it's obvious, but if it's not obvious, but you're worried about someone decompensating, because it usually takes a couple days to get to the hemorrhagic stage, and you may see people a little bit early before they end up into their concomitant multi-system organ failure. So the WHO basically says if they have severe thrombocytopenia, or if they have just basically severe pain, if they have any mucosal bleeding, or if they're altered, you should probably admit them early on and watch them, because they're probably going to get worse before they get better. All right, so take-home messages for dengue: fever, right? Up there with malaria. You're going to think of them both at the same time, and you're going to hope that they have a rash or GI distress, and that might lead you to dengue more than malaria. All right. Next, typhoid fever. So, first thing about typhoid fever, this is not salmonella diarrhea. It's a salmonella infection, but it's a salmonella bacteremia. It's a severe systemic illness with fever and abdominal pain. Fever, abdominal pain, typhoid fever. Fever, abdominal pain, typhoid. Fever, abdominal pain, typhoid. But no diarrhea. All right. You can basically see on the map, it's pretty much everywhere. There's high-risk regions, medium risk, but we've even had cases here in Oakland of people eating stale sea urchins and ending up with paratyphi bacteremia. So, this is going to follow people anywhere. And why is it? Because it's fecal-oral transmission. It's not diarrhea, but that's how you get it. It's still an enteric fever. You still get it from eating someone else's poop, because it came out of somebody's bile where they had the reservoir, ended up in your poop, in their poop, in your water, on your plate of food, and then back in your mouth. And you ended up with typhoid fever. And it sucks. So in week 1, you can see it's going to be really hard clinically to tell who's got typhoid, right? They're going to show up with basically looking like everything else we've talked about. They could look like malaria. They could look like dengue. You're not going to know, because they're going to have fever and they're going to feel like crap. They could have the flu for all you know in that initial week. Your only cue is if you notice what we were taught in med school, which I don't know how sensitive or specific it was. I couldn't really find that anywhere. The pulse temperature dissociation, right? Fever of 104, heart rate of 90, and you know what you're dealing with. But otherwise, you're kind of in the dark about whether this is really typhoid fever. When you will find it out is kind of by week 2, right? If this has been ongoing, you're starting to think that something is up if they're presenting to you on day 10 with the same symptoms that are continuing. And you may end up seeing this rash that is not nearly as severe as the dengue petechiae, and they call them rose spots. They're going to be slightly raised and pink maculopapulas that blanch, right? Dengue is going to be like a vasculitis, so the dengue rash is not going to blanch. And there are going to be these crops, usually around the nipple or the umbilicus, and you're going to still keep a pretty broad differential at this point because now you're dealing with fever and abdominal pain. But if you see the spots, you're kind of clued in. Week 3 is when people get sick as shit, right? That's when they end up perforating, they get this massive colitis, they start bleeding from ulcerations and lesions in their intestines, they get severe hepatosplenomegaly, and that's when they get really sick. So what are you going to do about typhoid? You're going to do blood cultures because that's how you're going to catch the typhoid, or the typhi, or the paratyphi. If they're uncomplicated, right, if they show up somewhere in week 1, early week 2, they haven't perforated or anything scary like that, and they look okay and they can tolerate POs, you can just treat them with Cipro. If they're complicated, they need to come in for ceftriaxone. And then, of course, if you see anyone with typhoid, you need to clean your hands. And that also, so let's just quickly make sure we have the take-home messages here. So typhoid, fever, abdominal pain. Typhoid. Fever, abdominal pain, typhoid. No diarrhea, because diarrhea is a separate topic. So I've broken up diarrhea into basically 3 things we need to think about, and this kind of helps us at home because the chronic diarrhea we don't really care about as much in itself, but the diarrhea epidemic, and then you have acute watery and acute bloody diarrhea. So let's focus on the easier one, which is going to be non-bloody diarrhea, right? Acute non-bloody diarrhea. Most of the time, it's a virus. Rotavirus is actually comparatively rare in the tropics compared to developed countries, but kids get much sicker from it. So over 50% require admission for rotavirus, and actually 600,000 kids die every year from rotavirus worldwide. That's crazy, right? And that's why we vaccinate our kids in the developed countries. But nearly all kids in the tropics, if they do survive it, have been infected with rotavirus by age 2. So they're going to be immune from there on out. Other things you're going to think about are the regular E. coli, that gives you watery diarrhea. You're going to think about Giardia, which has a super high prevalence. And in places where it's hyperendemic, and this is going to be a recurrent theme, infection is basically universal and asymptomatic. Everyone's got it, and they just pass it on to you, the sucker traveler, who doesn't have it yet. So you're going to get symptoms, but they're just used to it, right? Other things you're going to think about in the right setting are going to be cholera, or you're going to think about worms, which we'll talk about in a bit. And then you always are going to think about HIV, you're going to think about dengue, because there's GI distress associated with dengue, and if, there's a whole other list, but these kind of cover most of them. All right, diarrhea bloody. What are you going to do about? What do you think about for bloody? Differential is going to be mostly Shigella, bacillary dysentery, severe Shigella, which can be a pretty gnarly. It's usually rapid. People have tenesmus fever. They have mucus and blood in their poop, and this is clearly the most common. And when it's really severe, people can have up to 100 poops a day. That is crazy. Another thing we're going to see in the tropical region is Campylobacter. It's actually really common, and it's a common cause of bloody diarrhea. And then there's also amoebas. About 50 million infected, but only 10% of them have symptoms. And we always learn about the rare complications of amoebas, that they can go extraintestinal, they can end up in your portal circulation, they can become fulminant, and you can end up perforating, you can get liver abscesses, and they can basically perforate anywhere. There's all these cases about pericarditis from amoebic liver abscesses with even tamponade. They can migrate across the diaphragm and rupture into a fistula, and the classic anchovy sauce cough. Sounds gnarly. All right, and then there's salmonella. This is not S. typhae, right? S. typhae does not present with diarrhea. This is the regular salmonella, like from eating raw chicken. and this is the one that provides acute enterocolitis. It usually has invasive disease, meaning people will have a bit of a fever and they'll feel bad, but it's not the same as typhoid fever. All right, so I think this is kind of the way to think about diarrhea that I think of. There's bloody and non-bloody diarrhea. So what are you going to do about bloody diarrhea? If you have time and resources, you're going to get an O&P. And if you have an O&P and you see amoebas, which are usually pretty easy to see, you treat them with flagyl, with metronidazole. If there's a fever, you're going to probably treat them with Shigella, right? Because that's invasive, most likely invasive acute enterocolitis. If there's no fever, you're going to assume that it's enterohemorrhagic E. coli, and you're not going to treat them with antibiotics, right? You're supposed to not treat them, and it's supportive care. This is all very controversial and kind of a really simplistic way to do it, but it's kind of what the infectious disease experts recommend. Then, if it's non-bloody diarrhea, you always need to think about HIV, and then you're also going to get an O&P if you can, but these are the people who you don't generally care about as much. You're going to focus on hydration status in these folks, which is really the most important thing, and you're going to try oral solution versus IV fluids. The exception, of course, is cholera, where you need to take a bit of a different approach, but that is epidemic and rare and not something that you usually need to know about. And then the other things you're going to think about are, could this be a helminth? Could this be Giardia? Do you need to worry about it? Usually not. In most of the folks where people live, most of the folks who live in these areas, they all have helminths, they all have Giardia, and it doesn't really cause anybody any problems. It's more you or your Peace Corps friends or someone like that who's going to end up with the problem. Okay, so that's diarrhea. Bloody, non-bloody, treat the causes of bloody when appropriate. Non-bloody, generally focus on hydration status for both. Okay, we're going to breeze through the helminths of distinction because I think it's just interesting, and any talk on tropical medicine can't ignore the helminths, even though they're really minimal in terms of the symptomology that they tend to cause compared to some of these other bad boys that we've talked about. So schistosomiasis is by far the most common problem child. There's about 1 in 30 people worldwide have it, but it does kill about 200,000 people a year, which is pretty high. And you can see it has pretty wide variation of where it's found and where it's endemic. You see over most of Africa, a lot of the Middle East, and parts of South and Southeast Asia, and parts of Eastern South America with a different kind of schistosoma than what they have in the rest of the world, but still problematic sometimes as well. So here's another life cycle picture, which I focus on just a couple things. So if you look at the top, you can see where it says number 5, the cercaria that come out of the snails. The snails are in the water, and they release these little sporocyte things that basically the thing to know is that they go in through the skin. That's how schistosoma gets you. It gets through the skin in water. So you have to be in water where there are snails, and then you get these little cercaria get into your body. They penetrate the skin. From there, they have a pretty crazy life cycle. They're going to go through the skin, and they're going to go into your blood and lymph, and from there they go where all blood and lymph goes, which is to the heart and lungs. Then they squeeze out through the pulmonary capillaries, get into the arterial circulation, right? Because if they're going in the blood, they're getting into the venous circulation. They get into the arterial circulation, and then they lodge in the mesenteric, the splanchnic, and the portal circulation, right? So that's like they're these tiny beds, and they just latch on there, and that's where they get stuck and cause their mess. And some of the females will make eggs that can then squeeze out from the blood vessels into the bladder or into the intestines, and they continue to cause problems there, right? So enters through the skin, ends up in the splanchnic and portal circulation, then goes into the bladder and the feces. All right, that's what you need to know about the schistosoma life cycle. So acute presentation, which you will probably never see in anyone from an endemic area, but again, people who have not been there before and show up in your clinic who have an itchy rash, the first thing you're going to think about is schistosomiasis. They have an itchy rash and they've been in anywhere in water where those parts were in the water, it's going to be schistosomiasis until proven otherwise. Otherwise known as the swimmer's itch. That's where these sporocyte things, I forget what they're called, but they go in through the skin and they cause this urticarial rash, usually on the legs or feet. It's usually within a day of exposure, and it's going to itch like crazy for a week. From there, if they make it through that part and don't get treated, they end up in the chronic phase. And this is more likely what you'll see in the endemic areas is people with chronic illness. So this is from the schistosomas that have lodged in the GI tract or in the hepatic tract, where people are going to get IBS symptoms. They can get anemia because they end up with ulcerations and bleeding. In the GU tract, they can end up with hematuria. People can get cirrhosis because it clogs up all the portal circulation. And then actually, for reasons that I don't totally understand, even in people with no other symptoms, they can end up with neurologic findings. I think the eggs can migrate out, is what I remember, into the CNS, and you can get transverse myelitis, you can get altered mental status, you can end up with seizures, and this is the main reason that people treat, is for these neuro findings. All right, so how are you going to diagnose schistosomiasis? You're going to maybe see something unusual labs. Maybe they're anemic. Maybe they're going to have hematuria. You're going to look for it in the poop with an O&P. Maybe you'll see the eggs. Interestingly, the eosinophilia is quite common in people with schistosomiasis, and how specific it is unclear because a lot we're going to find people have all kinds of helminths and are probably going to have eosinophilia from all of them. So it's not really that helpful. But if you're already suspecting schistosomiasis for some other reason, then the eosinophilia can be really helpful. Up to 2/3 of patients will have it. But I'm not really sure what to do with it in terms of my positive predictive value of eosinophilia. And then how are you going to treat it? This is one of three we're going to hear. This is the first one is praziquantel, 1 or 2 doses. You're not going to remember the dosing. You're not going to remember which med for which worm. So I wouldn't worry about it. Just get the book, and that will remind you every time about how to treat. Some other helminths of distinction. These are the other, quote, itchy water worms. There's the cutaneous larva migrans. I think the thing to know is that they can get really long. It's also a waterborne exposure from the larvae, and they kind of get stuck in the skin, and it goes pretty slow, a couple millimeters, maybe a couple centimeters a day, and you're going to treat these with albendazole or ivermectin. Look it up. The other one is strongyloides. This is a really disseminated infection of strongyloides. I think the thing to know what's different between strongyloides and the cutaneous larva migrans is going to be kind of a similar thing. There's going to be infected skin or membranes. It's going to be super itchy. This is one that's spread through human feces. Most people are infected for life and never even know it later, although you can get these symptoms at any point during the life cycle of the worm. But so if they show up, then you'll be able to treat them, but most people won't even know that they have strongyloides, and will just be passing it away in their poop. Yeah, isn't that great? But I think the thing to know about strongyloides is it goes really fast. So it can grow, once it starts having the skin manifestations, 5 to 10 centimeters a day is spreading of the strongyloides. There you go. Okay. Other helminths of distinction, the liver flukes, the clonorchus, and opisthorchus. This is all transmitted by fish, usually in East Asia, freshwater fish. So I think the thing to know about the clonorchus, the liver flukes, is that they can cause biliary duct obstruction. So, it's going to look clinically to us the same as some other kind of biliary obstruction, whether it's choledocholithiasis or maybe even cholecystitis, but you're going to treat this one with praziquantel. So remember, biliary duct obstruction, helminths of distinction, liver flukes. Okay. The other one, just interesting to know, is ascariasis, because 25% of the world is infected with ascariasis. That is a lot of people. And even in endemic areas, it can be up to 95%. And pretty low mortality and morbidity. I mean, it's only 60,000 deaths. So for the number of people who are infected, it's not too bad. And this is the one where you'll know because people are going to poop out spaghetti into the toilet. And that is ascariasis. And it's going to be super common. And if they have it, then you can treat them with albendazole. The other thing is, once in a while you can get this severe, like this was an operative pathology specimen. This guy had an obstruction. So you can get enough worms, eventually they can obstruct your intestines, but usually it's not that big of a deal. And the people will be asymptomatic and probably with less asthma, as the epidemiology suggests. Okay, the last helminth of distinction is the tapeworms. There's the Taenia saginata and Taenia solium. Usually these are asymptomatic, and I just include them because they're also super common, and we see them actually not infrequently as causes of seizures from neurocysticercosis. Now, I think the thing to just clarify, because we're here, is that the way this works is there's sort of a 2-stage infection. So the way you end up with neurocysticercosis is your buddy at the hamburger stand has a tapeworm. He's constantly shedding eggs into his poop. He doesn't clean his hands. You end up with tapeworm eggs in your hamburger, eat the eggs, and the eggs turn into larvae and cysts in your brain and liver, right? It's not, if you eat infected meat, like from a pig that had the cysts themselves, you're going to end up with the worm, but not neurocystis cercosis. In order to get neurocystis cercosis, the cysts in your brain or liver, you need to actually eat the eggs, which means you're either getting it from your own tapeworm, auto-inoculating yourself, or you're getting it from somebody else's tapeworm, but not from an animal that's infected. Common misconception. Okay, now that that's been cleared up, we've got our helmets of distinction, okay? Not really much to remember or know. I think just that lots of people have them. They're usually asymptomatic. And the ones to think about, I guess, are the itchy water worms, where you can maybe do something about it. And we'll kind of review that one last time. So next up is the leptospirosis. This is our spirochete infection extraordinaire. I call this the syphilis of the rodent world. The way it works is the most common zoonosis, the most common animal-borne illness in the world. And we will actually see this one probably at home because it's not that far from us, especially places like Hawaii and in parts of South America. And even here in North America, you'll see leptospirosis. 50% of exposures are occupational, people who work with animals, and then the other 50% are these epidemic exposures. So the way it works is it comes from mostly rat piss and poop, and then seasonal fluctuations like hurricanes and flooding wash all the poop out into the street or into places where people are. People have little tiny cuts or ulcers or whatever on their feet, and they get contaminated with the spirochetes, and it basically gets in. So it's sort of like, if you think about chancre for syphilis, the leptospirosis needs a portal in order to get in through, but then once it gets in, it kind of does the same thing that syphilis would do, just minus the original chancre. Clinically, initially, it's going to look like a lot of the other stuff we've talked about, right? And you're going to have a hard time telling it from dengue, malaria. Some of the clues are that during this febrile prodrome, I call it thunderclap sepsis, which, some of these other things are going to give you thunderclap sepsis, typhoid, dengue, malaria. But if someone seems really meningeal, of course you're going to be thinking about someone who's altered with severe dengue, but if it's not adding up for hemorrhagic dengue, it's not adding up for cerebral malaria, you may start thinking about leptospirosis because it has really common rates, high rates of meningeal inflammation. And then, so there's the febrile part, but then this is the part you really need to remember about leptospirosis is jaundice and renal failure. Right? This is the secondary immune response to the spirochetes. And remember, jaundice and renal failure. If you see that combination, jaundice and renal failure, you're going to think leptospirosis. Jaundice and renal failure, leptospirosis. Right? It could be severe malaria, sure. But if you've ruled out malaria, if you're not seeing the smears, seeing the leptospirosis is actually a lot harder, right? You have to look at a dark field microscopy the way you diagnose syphilis, and who has dark field microscopes in the tropical world, right? Unless you're in a fancy hospital. So if you've been able to get the smears, and the smears don't have malaria, the only other thing really left on your differential here is if you're not thinking this is severe hemorrhagic dengue and they're a multi-organ system failure because they don't have a terrible rash and it just doesn't make sense, I want you to remember jaundice and renal failure, leptospirosis, especially because we're going to see this one at home. Other things, the other clue that may set you off to leptospirosis early is uveitis. Just another thing to remember, jaundice, renal failure, leptospirosis, maybe uveitis, right? Because the spirochetes go everywhere, including the aqueous humor, and that is one of these unique things that may tip you off to this being the disease process and not one of these other ones we talked about. How are you going to treat it? The way we treat any bad spirochete infection, with intravenous penicillin. Right? We know that one from home. Syphilis, it's all in the same game, all in the same boat. So leptospirosis, jaundice, renal failure, penicillin. All right. Now the miscellany, and we're almost at the end. So I was just going to touch on rabies because it's something you may actually see, but basically if you're seeing rabies, that person is toast. Right? They've got furious rabies, as it's called, or they can have paralytic rabies, which is a lot more rare. It basically starts with hydrophobia. So if someone's scared of water and they're looking weird and sick and acting strange, you should probably get away from them because they may give you the rabies. So It's kind of sad, but there's not really much to do once you're here. And it starts with hydrophobia, and then people are just scared and have laryngospasm from everything. And it sounds really terrifying, especially from videos and things that I've watched that I haven't included on here. Just watch them before you go, and then you will keep your distance from anything that looks rabid. The other thing to talk about is tetanus. So, because this is huge, right? Why is this at the end in the miscellaneous? Because I couldn't fit it anywhere else in the other groups. But tetanus, 800,000 people are dying each year of tetanus. And most of the time, it's neonates, right? So it's pretty sad. Kids are dying of tetanus and rotavirus in the world, and malaria. Those are sort of the top ones for little kids. The thing to remember about tetanus up front is that immunizing pregnant women is actually a super effective strategy for protecting neonates. So if you want to put something in your fanny pack and you're going to a place where you're going to deal with a lot of pregnant women, because where are you not going to deal with a lot of pregnant women? And there's poor access to resources, consider bringing a gang load of Tdap. And you can save a lot of kids' lives by protecting them against tetanus, because they're going to contract it during prolonged labors or even sometimes uncomplicated labor. All right, think about it. This is what it's going to look like. You're going to see the muscle contractions in a couple different age ranges. The first sign is usually going to be trismus up in the mouth, and then it's going to spread everywhere else to other and larger muscle groups. It can also include autonomic dysfunction, and you can have laryngeal spasm. You can have all kinds of spasm. And the way you're going to treat it is based on the grading. So these guys in those pictures actually weren't that severe. They were still able to breathe. Really bad people, if you have the resources, you're going to intubate them and paralyze them. But if you don't have the resources, or you just don't think they're as severe, you're going to treat them with benzos. But again, you need a vent, right? If you're going to paralyze someone, you need a vent, and not everywhere. I mean, actually, in very few places are you going to have vents. Then there's this whole gang of things that you should be treating all patients that is recommended by the tropical medicine gurus. You're probably not going to remember all of them, except that everyone should get the antiserum. Remember cleaning the wound. Remember cleaning the wound. You're not going to win the tetanus battle. You can treat them symptomatically, but if you don't clean the wound, you're not going to help the tetanus, really, right? If it's coming from a wound. So remember that. And then it's how you're going to see it in adults. You want to treat them with antibiotics. It's going to be based on what you have available. And then remember, if you brought that gang of Tdap, anyone who had tetanus should get vaccinated before they go, because they can get it again. Oh, all right. The last thing I'm going to mention, just because it's so obvious and it's so common, and it's just have it on your radar, especially if you're watching this before you're filling your fanny pack and you have access to meds, take a bunch of azithromycin, because here's a case of chlamydia in the eye spread by flies. It starts as a conjunctivitis, and it actually irritates the eyelids so bad that they then scratch the cornea, and people end up with scarred and ulcerated corneas and can't see. And the treatment is 1 gram of azithromycin, like our normal chlamydia. You just treat them normally, and you prevent blindness. 1 dose. So easy. Something we can really do to save people's vision. It's pretty amazing. Okay, that was a lot of information. We're going to focus on some take-home messages. I'm going to repeat some mantras here for you. Remember, get that Oxford Handbook before you go. It's going to be super helpful and will fit in your fanny pack or any other bag that you're bringing. Fever, malaria. Always consider it. Fever, malaria. Fever, malaria. If there's fever and a rash, it's probably not malaria. Then it's probably dengue or typhoid fever. Fever and rash, dengue, typhoid. How about fever and abdominal pain? You're going to think typhoid, then dengue, right? Typhoid, then dengue, because dengue can give you the GI distress. So fever and rash, dengue and typhoid, fever and abdominal pain, typhoid and dengue. If there's diarrhea, think if it's non-bloody or bloody, and maybe get an O&P, and then treat the bloody diarrhea appropriately. Itchy rash, acute helminths. Schistosomiasis, or these other ones that you're probably not going to see in anyone other than a traveler. But remember, everyone is chronically infected with helminths. What were the other ones? Fever, jaundice and renal failure, leptospirosis. Sorry, I didn't put that one on here. And yeah, I think that's it. Thanks for listening. I hope this was helpful. If you want to give me any feedback, please do. My email address is up on the website. And yeah, I hope you enjoyed this talk. Cheers.